Hello everyone, welcome to Nurse Expertise and welcome to the second part of Pacemaker. In this video we will talk about modes of pacing in detail, so stay with us till the end. Well, Hassan, would you like a brief explanation about this device?
Sure. Pacemakers are devices that help regulate the heartbeats of people who have abnormal heart rhythms. They are implanted under the skin, usually near the collarbone, and they have wires that connect to the heart chambers. The pacemakers send electrical impulses to the heart to make it beat at a normal rate and rhythm.
But how do the pacemakers know when to send the impulses? And how much?
Well, that's a good question. Modern pacemakers have different features and functions that allow them to adjust to the needs of the patients and the situation. To make it easier for doctors and nurses to understand and communicate about the different types of pacemakers, there is a universal code that describes them.
A universal code. What does that mean?
It means that there is a standard way of naming the pacemakers based on their characteristics. The code consists of letters and numbers. The temporary pacing mode is abbreviated as the three-letter acronym, but the permanent pacemakers are abbreviated as the five-letter acronym. That indicates the following. The first letter tells us which chamber of the heart is paced by the pacemaker. It can be A for atrium, V for ventricle, or D for both. The second letter tells us which chamber of the heart is sensed by the pacemaker. It can be O for none, A for atrium, V for ventricle, or D for both. The third letter tells us how the pacemaker responds to the signals it sends from the heart. It can be O for none, I for inhibited, T for triggered, or D for both. The fourth letter tells us how the pacemaker can be programmed or adjusted. It can be O for none, P for simple programmable, M for multi-programmable, C for communicating, or R for rate modulated. The fifth letter tells us if the pacemaker has any antiarrhythmic function. It can be O for none, P for pacing, S for shock, or D for both. So, for example, a pacemaker that is called AAAI means that it paces and senses the atrium and it inhibits itself if it detects a natural heartbeat in the atrium. A pacemaker that is called DDDR means that it paces and senses both chambers. It can inhibit or trigger itself depending on the signals. It can be programmed and adjusted in different ways, and it can also pace or shock the heart to prevent or treat arrhythmias.
That's quite informative. Moving on, can you explain the significance of the response to sensing being off in pacemakers, and what is inhibit mode?
When response to sensing is off, the pacemaker paces at a programmed rate regardless of the intrinsic electrical activity of the heart. And to your second question, at inhibit mode, the pacemaker can sense the electrical activity and withhold pacing when not required. And if the atrium is targeted to sense and pace, the pacemaker can adapt to the intrinsic atrial rate and should be able to pace when needed and inhibit when not required.
Got it. Now, could you elaborate on the dual chamber modes in pacemakers?
Certainly. The dual chamber modes can further divided into tracking modes and non-tracking modes. Tracking modes are designed to follow the intrinsic activity of the atrium and adjust to ventricular pacing accordingly, such as DDD or VDD. The most common tracking mode is called DDD. This means that it paces and senses both chambers of the heart, and it can inhibit or trigger itself depending on the signals. This type of pacemaker is very sophisticated, and it can adapt to the natural rhythm of the heart and mimic the normal conduction as much as possible. It can also maintain the coordination between the atrium and the ventricle, which is important for the efficiency and function of the heart. The DDD pacemaker has 4 different patterns of pacing. Depending on the situation, they are ASVS. This means that the pacemaker senses a natural heartbeat in both chambers, and it does not pace at all. This is used when the patient has a good function of both the sinus node and the AV node, which are the natural pacemakers of the heart. The other pattern is ASVP. This means that the pacemaker senses a natural heartbeat in the atrium, but it paces the ventricle. This is used when the patient has a good function of the sinus node, but a poor function of the AV node, which causes a delay or a block in the conduction from the atrium to the ventricle. The other pattern is APVS. This means that the pacemaker paces the atrium, but it senses a natural heartbeat in the ventricle. This is used when the patient has a poor function of the sinus node, but a good function of the AV node, which allows a normal conduction from the atrium to the ventricle. The last pattern is APVP. This means that the pacemaker paces both chambers of the heart. This is used when the patient has a poor function of both the sinus node and the AV node, which causes a complete loss of the natural rhythm and conduction of the heart.
I see. And what about the other tracking mode, VDD?
VDD is a mode that only paces in the ventricle, but senses in both the atrium and ventricle. It can also inhibit or trigger the ventricular pacing based on the sensed signals. Intrinsic QRS can inhibit ventricular pacing, and intrinsic P-wave can trigger an AV delay. In this mode, one cannot pace the atrium, but an intrinsic atrial activity can trigger an AV delay, resulting in P-wave tracking and possibly maintaining AV synchrony. VDD mode should only be used in patients with good SA node function. It might be used in a situation where the patient has a high pacing threshold in the atrium. This way, the pacemaker will be able to sense in the atrium, maintain AV synchrony, and not waste battery life by pacing in the high threshold atrium.
I understand. And what are the drawbacks of VDD mode?
The main drawback of VDD mode is that it can cause AV dissociation if the sinus node function drops below the programmed low rate of the pacemaker. This means that the atrium and ventricle will beat at different rates, which can impair the cardiac output and cause symptoms such as dizziness, fatigue, or shortness of breath. Therefore, VDD mode should only be used in patients who have a stable and adequate sinus node function.
Thank you for explaining that. Now, let's move on to the non-tracking modes. What are they and when are they used?
Non-tracking modes are modes that do not follow the atrial activity and do not adjust the ventricular pacing accordingly, such as DDI and DOO. They are used in patients who have atrial tachyarrhythmias, which are fast and irregular heart rhythms in the atrium, such as atrial fibrillation or atrial flutter. These rhythms can cause the pacemaker to track the atrium and pace the ventricle at a high rate, which can be dangerous and uncomfortable for the patient. By using non-tracking modes, the pacemaker can prevent this from happening and pace the ventricle at a safe and comfortable rate.
And what are the examples of non-tracking modes?
The most common non-tracking mode is DDI. This stands for dual pacing, dual sensing, and inhibit response. This means that the pacemaker can pace and sense in both the atrium and ventricle, but it can only inhibit the pacing in either chamber. This mode's primary use is in patients with atrial tachyarrhythmias and mode switch algorithms. DDI mode will result in AV dissociation if the atrial rate goes higher than the set rate. P-wave tracking is excellent for AV synchrony. However, if the patient goes into atrial fibrillation with rapid heart rate, one does not want to track the atrium and pace the ventricle at a high rate.
I see. And what about the other non-tracking mode, DOO?
DOO is a mode that paces in both the atrium and ventricle, but does not sense in either chamber. It also does not respond to any sensed signals. This mode results in AV sequential pacing at the lower rate limit, regardless of the heart's own intrinsic activity. DOO mode is asynchronous pacing and is usually used only in certain situations, such as when a magnet is placed over a pacemaker or sometimes when a patient is having surgery.
Fascinating. Lastly, can you tell about rate response in pacemakers?
Certainly, rate response or rate adaptive pacing is used in patients with chronotropic incompetence. Chronotropic incompetence is defined as the inability of the heart to appropriately increase its rate with increased activity or metabolic demand that leads to exercise intolerance. Usually there is a problem with SA node function. The pacemaker utilizes its sensing ability with the aid of sensors that can sense motion or minute ventilation changes according to the activity and pace the heart at a required rate. No.
Thank you, Hassan, for sharing this content with us. Any last words?
Thank you for your interest and attention. I would like to say that a pacemaker implantation is a safe and effective procedure that can improve the quality of life and the survival of patients with heart rhythm problems. However, it is not a cure and it requires ongoing care and follow-up. Therefore, I encourage the patients who have a pacemaker or who may need one to be well informed and follow the instructions and recommendations of their healthcare providers, and to report any concerns or issues that they may have. I also invite the viewers who have any questions or comments to leave them below. And thank you for watching, and don't forget to subscribe to Nurse Expertise. Stay healthy, stay informed.